Good evening, good afternoon, and good morning to all those who are listening from all over the world. Thank you, Clarinet and Rupsa, for airing us, and believe you are all keeping absolutely fine. I am thankful to Dr. Raju Kalidindi, who is moderating this particular webinar. Of course, I am also joining Raju in moderating. Raju, as you know, is a senior anesthesiologist with the UK Health Systems and is an administrator with the British Physician Associations organization. And he is a regular attendee with all our national conferences with the ISA as well as with the Indian College. He is joined by Sonia and Tara Ramphal.
Okay. Thank you very much, Dr. RADHAKRISHNAN, for your kind introduction. And also good evening to everybody and participating in this conference, and thank you very much to Dr. Jayashree, Shrud, Sanesh, Ruspa, Sonia, and Tara. And okay, today's our webinar is the main theme of the webinar is thinking beyond perioperative mortality. We have okay. Before that one, I would also thank the Indian College of Anaesthetists for not only providing this free noble activity of continuing medical education of anesthesiologists throughout the worldwide, but also for the direct, indirect contribution to the patient's safety by providing this noble educational activity to the anesthesiologist. I also thank you on behalf of me and the panelists for giving an opportunity for us to join with you in this noble activity. I am privileged and thankful to my colleagues, Professor Rampal and Dr. Sonia Verma, who came forward and volunteered to participate in this webinar to share their expertise. I welcome Professor Rampal and Dr. Verma to the webinar. Now, so we have the four topics in the today. Of which the first topic is the perioperative rehabilitation and cardiopulmonary exercise test interpretation. Both the topics will be delivered by Professor Rampal. And our third topic is sedation in procedural sedation in non-theater environment. And then followed by, I will present, this will be delivered by Dr. Sonia Verma. And after that, I will present my case, management of parturient with Familial Hyperchylomicronaemia Syndromes with Hypertryglyceredimia. Our next presentation is the procedural sedation in adult patients in a non-theater environment. Okay, whenever we hear sedation, everybody thinks that sedation is very simple. We will send some of the junior most to administer the sedation. But sedation, if not administered properly, it can have a catastrophic effects, especially when we have seen one incident with Mr. Michael Jackson. He was succumbed to the sedation. So what is it? So taking into consideration every hospital need a one responsible person who can look after the sedation practices in the hospital to keep the mortality and morbidity in control. So we have one person who has experience in our department, and Dr. Verma. Dr. Sonia Verma has 28 years of experience in the NHS in the UK, and she's working as a consultant anesthetist at Medway NHS Foundation Trust for the last 22 years. She is duly accredited with her anesthesia qualifications. She has done her MD from Tata Memorial Hospital, Bombay, and later did her FRCA and CCT from UK. She is the lead for sedation for more than 9 years in our hospital. She is responsible for looking after the sedation policies and the training of all the staff who are involved in sedation. She conducts a biannual sedation workshop open to all staff members in the hospital. So Dr. Verma will share her expertise on sedation with all of us. Welcome, Dr. Verma.
Thank you very much, Dr. Kalidindi, for your kind introduction. Are you able to hear me?
Yeah, I got you.
Thank you. I would also like to thank the Indian College of Anaesthesiologists webinar committee for giving me this opportunity to share my experience as a sedation lead for my hospital for the last 9 years. I have no conflict of interest during this talk. The topic for my discussion today is procedural sedation in non-theatre environment. I would like to dissect my title a little bit. Procedural sedation means it is sedation for an elective procedure. This presentation today is covering only adult sedation. We are not going to discuss pediatrics at all. Non-theatre environment is usually a remote site, and in my hospital, it is done in various areas, such as endoscopy, interventional cardiology suite, interventional radiology suite, or in the A&E department. And there they are doing various procedures such as a gastroscopy, a bronchoscopy, a device insertion, cardioversion, removal of a lesion with the CT or MRI imaging, or a joint manipulation. So various different procedures are being done in the hospital in different areas. The most important question for us to realize today is, who is giving this sedation? I would say 95% of the time it is the nurses. There are some doctors who are, if available, able to give the sedation. Sometimes the anesthetists get involved. But most of the time in America and in Europe, we have got physician associates. Physician associates are highly trained and skilled practitioners that work under the direction of a consultant anesthetist. There are no PAs in UK, so we are left to train our nurses. In 2019, the American College of Emergency Physicians defined procedural sedation as a technique of administering sedatives or dissociative agents with or without analgesics to induce a state that allows the patient to tolerate unpleasant procedures while maintaining cardiorespiratory functions. When explaining the different stages of sedation to nurses, I prefer to use the AVPU score. This score is made by the American College of Anesthesiologists, and they define sedation as a continuum of sedation, as minimal sedation, moderate sedation, deep sedation, or general anesthesia. As an anesthetist, we understand it very well. But when you're explaining it to the nurses, I go with the AVPU score. This is a very popular score in UK amongst all healthcare providers. It helps to assess and monitor a patient's brain function. As an anesthetist, we look at the responsiveness, airway, ventilation, and the cardiovascular function of the patient. The aim of giving good sedation is that we should be in the moderate sedation or in the verbal section of this column. And with that, the patient is able to give you a response to a verbal or a tactile stimulus. There should be no airway intervention required. The ventilation is adequate, and usually the cardiovascular function is maintained. The Academy of Medical Royal Colleges in the UK, comprising of 24 Royal Colleges, including the Royal College of Anaesthetists, the Royal College of Emergency Physicians, Emergency Medicine, and they produced in 2013, in October, the first robust guideline for sedation. This was updated in 2021, and it was the first read for me when I joined as the sedation lead in the hospital. The Royal College of Anaesthetists has produced a few guidelines, which you can see below. as a guidelines for the provision of anesthesia services in non-theater environment, patient information leaflet, and a leaflet to explain sedation. In our hospital, so far, the procedures that have been done include endoscopy, about 9,000 cases, interventional cardiology, 900 cases, interventional radiology, 76 cases. Unfortunately, I don't have a data to tell you about what cases were done in A&E, but approximately it's about 1 or 2 manipulations of joints which are done per week. In looking at these 10,000 cases, the adverse events recorded was as little as 0.005%. So fortunately, we are doing something quite good. The goals of sedation for any patient or for a doctor or a nurse who is taking part in the sedation should be to decrease the anxiety of the patient, to give very good amnesia so that they don't remember very much, excellent analgesia, and to keep the patient immobile. There are lots of benefits of sedation, but we have to acknowledge it comes with risks. So main risks are cardiac depression, hypoventilation, laryngeal spasm, airway obstruction, apnea, and even death of the patient can occur. For me, the main remit when I took up the sedation lead was the training of non-anesthetist staff. And it came like a teamwork. I like this picture because not one person can achieve this beautiful pyramid that they have made. So you have to train each and every part of the team. Firstly, it was the nurses. So they had to do a competency sheet, which I made along with their nurse in charge. And we developed a competency sheet so that the nurses are aware of what they are doing and why. They all had to learn how to put an intravenous cannula. Sometimes doctors can do it, sometimes they can't. But nurses are mainly the ones who are going to be using it. So they all need to do the course, which is done in the sim lab. They are all trained in the BLS or the ILS courses. And they also have to do a recovery course, which is being run in the hospital. Besides that, I tend to do regular lectures in respective units. I tend to run simulation scenarios either in the lab or in situ. The nurses prefer the in situ situation because then they are able to find where they have kept all the resus equipment or what do they need more to be kept in the room. The doctors who are not anesthetists, they have sedation incorporated in their syllabus. So they have learned about it as well. Regular presentation and discussion of adverse events is done by myself so that they are able to see what problems they have had, and different people might have had different issues, and they can all learn from it. Everybody is encouraged to attend courses, either nationally or in-house. There is a sedation workshop, which I do twice a year and is very popular. There is telephonic pre-assessment that is done by the nurses. First of all, we try to assess what is the patient's age and frailty of the patient. We all have seen patients who are 60 years old, but they actually look like an 80-year-old, and vice versa. So it is not the age that is important. It is how frail the patient is. The more frail they are, the more adverse events can occur, and they are very sensitive to drugs. Do they have a cardiac history? Do they have a renal or a liver problem? Are they drinking excessively or smoking? Do they have COPD? Do they have diabetes? Are they on medication like anticoagulant drugs, which may need alteration to change like a warfarin into a fragment, or to stop some of the oral anticoagulant drugs? So this is done about a month before the patient is scheduled for any procedure. We are encouraging them to do a ASA grading so that only ASA 1 and 2 cases can be done in the remote areas. When the ASA grade is more than 3, we say that it should be done in theaters along with the presence of an anaesthetist. You all are familiar with the ASA grading. So this is laminated and is kept in all the pre-assessment units that they are doing it. In the telephonic pre-assessment, we are also very much trying to anticipate any airway complications by asking the patient, what is their BMI? If the BMI is more than 40, we could be having some problems. Do they have any loose teeth or missing teeth in the front? Do they wear any dentures? The collar size in men, if it is more than 17, is going to be difficult in mask ventilation or even intubation. Does the patient give you a history of sleep apnea or snoring? And finally, do they have any restricted movements of their neck because of arthritis, neck surgery, radiotherapy, or scleroderma? In my training to the nurses, I talk about the following things that they should think about. Which of the patient may be difficult to ventilate, may be quite predictably desaturate, such as a high BMI, more likely to regurgitate or aspirate, again like a high BMI, or drop their blood pressure like the elderly. So I tend to show them these pictures so that they are able to gauge which patient could be a difficult one. High BMI or a patient with lesion on the face or scars limiting the neck movement, or a patient with thyroid who will get a complete obstruction if they lie down. And sometimes patients who have congenital abnormalities like a Pierre-Robin syndrome. Patients with beards are usually having a receding chin that they are hiding. When you examine a patient with a difficult neck movement, this is how they look, that they are not able to extend their neck and they move their whole body. Patients with missing teeth and a very loose dentation may lose their teeth if you're going to put anything in their mouth. And very costly, expensive teeth, you have to tell them about it. We can cause a damage to them, or they might have dentures which can get swallowed. Do they have sleep apnea, and have they got a spine which doesn't move at all? There should be some assessment which is done on the day of the procedure, like a brief physical examination, blood pressure, heart rate, saturation, respiratory rate, to get the basic one that the patient is on breathing air. So you need to know these before you start the procedure. The height, weight, and the BMI of the patient, how much is the patient fasting, what are the allergies and medication they take. In the elderly, we tend to encourage them to do a pre-op ECG, and if there was some blood test needed for the procedure. Also do an evaluation of the mouth to look at the mouth opening. They are taught about the Mallampati score, look at the neck movement, loose teeth, dentures, bleeding, and look at the tongue size. The fasting guidelines, as we all know, the Royal College of Anaesthetists still is saying 2, 6, and 8, which is for general anesthesia. However, some other college guidelines have been produced who are okay with 2, 4, and 6. 2 is for clear fluid, 4 is for a light breakfast, and 6 is for a light meal. A full equipment checklist should be done before the sedation starts, and this should always be done in a special dedicated room. So look at where the full resuscitation equipment is kept. There should be a continuous high flow oxygen either on the pipeline or to make sure that the cylinder is full, with appropriate devices for administration. We'll go to that in a minute. High pressure suction should be there in the room, a tipping trolley, and manual handling devices for patients with high BMI. We say that there should be a 3 personnel model of people in the room. There should be a doctor who is doing the procedure. He's not responsible for giving sedation. The person giving sedation is either a qualified nurse or another doctor who will then give little by little in increments and titrate the dose. There should be another nurse who is going to monitor the patient and document it on paper. Not everywhere do we have computerized system. If the patient is high risk, there should be an anesthetist in the room as well. The WHO checklist is always done before the operator starts or before the nurse starts giving any sedation. Monitoring during the procedure, the most important is clinical observation. In what stage of sedation is your patient? Are they alert? Are they in the verbal? Are they in the pain? Or are they unconscious? AVPU again and again. One should cycle the blood pressure every 2 to 5 minutes because, as we know, sedation drugs are going to decrease the blood pressure. There should be a continuous pulse oximetry for every patient. The ECG to be done in elderly. A capnography is now a recommended one, but very shortly it is going to become a mandatory monitoring equipment. As per the AAGBI and the ASA, this slide is depicting what we just said. So we've got the ECG, pulse oximeter, capnograph, blood pressure, temperature only for long cases. So as I said, capnography at the moment is recommended, but soon will become mandatory. So far, pulse oximeter has been considered as a okay monitor for sedation, but numerous articles now are showing that capnography catches early apnea, what the pulse oximeter catches much later. Abnormal end-tidal CO2 findings are observed with acute respiratory events that every anesthetist knows. This has now been recommended by the Royal College of Anaesthetists, the AAGBI of UK, ASA in America, and the European Board of Anaesthetists. It is for the early detection of apnea that we need the capnography. This is a screenshot of the case I was doing, and I've got the full monitoring, and the patient is breathing and is having a propofol TCI for injection to be done by an orthopedic surgeon. And the patient slightly moved. So I increased the propofol TCI, and you see what happened over here. Slowly the capnograph has come down, but the pulse oximeter is the same. We all know it takes a very long time for apnea for it to go down, minimum of 2 to 3 minutes, whereas the capnograph went off immediately. The next thing I did was head tilt, chin lift, jaw thrust, and maybe even put an airway if you need it. Capnography in sedation can be done with the help of capnomask and nasal prongs, which are easily available in the hospital. Coming on to the drugs that are given for the procedure, oxygen is given to all the patients. Midazolam is given in increments of 0.5 to 1 milligram with a maximum of 5 milligrams only. Fentanyl is the other drug that we use for pain relief, 25 microgram in intravenous increments to a maximum of 100 micrograms. These two drugs are standard in all the units that are using sedation in our hospital. Saline flush should be done at the end of each case, as in one of the cases we found that the flush was done in the recovery area and the patient got sedated. It was a very elderly, frail patient. Propofol usage is restricted in UK only for anesthetists and some A&E doctors who have been trained by anesthetists to give as intermittent boluses or in PCI in a TCI pump. There are other adjuncts besides the medication and the intravenous route. We also tend to give gas and air a lot. There is paracetamol and there is non-steroidals. If you're not contraindicated, they are advised to be given. Ketamine is not used that much in the UK. I believe in India, ketamine and propofol called ketopropofol is being used a lot. I don't have much experience with that. Remimazolam is coming in over here in UK. I've had a word with the company rep, And it sounds very promising because it's very short acting and it doesn't have the side effect like midazolam. Dexmedetomidine was promoted as a sedation drug, but having read some of the papers, I don't think it has taken off. The new latest medication I read about was oliceranide, which is a new analgesic and probably has less side effects than the opiates. I don't have any experience with that one either. So when we come to see, we are going to give sedation with the risk-benefit ratio to be taken into consideration. In the UK, there is a DATEX form that is filled in if there is any adverse event. It's a risk management information system. So for sedation, it is told to all the departments that if you get a decreased saturation for a prolonged time, less than 90%, please fill in a form. If there is hypotension with the systolic blood pressure less than 90, you need to do a DATEX. If you're going to use any of the reversal agents, if there is an unplanned admission to the hospital, or if there is a cardiac arrest, then it has to be filled in. Common themes that have come from the DATEX forms from my hospital, that the adverse events are happening in elderly, in frail patients, in patients with lot of comorbidities, patients who are heavy smokers or heavy alcoholics, liver and kidney failure patients. In the various workshops I do, I try and tell them recognition of the sick patient and anticipating problems such as hypotension and hypoxia will help you to prevent a cardiac arrest. This is the basis of which an anesthetist works. We recognize people very quickly, we anticipate problems, that is the anesthetist, and we help in that way to prevent a catastrophe from happening in the room. I was very lucky to attend a webinar last year in May, done by the European Society of Anesthesiologists and Intensive Care. The topic was procedural sedation, what's new? So I was quite interested, what's new? And it was done by Dr. Clemens Bernards, who is working in Netherlands. That they are doing about 2,000 to 3,000 procedures per day with the help of physician assistants, and they are being supervised by one dedicated consultant anesthetist who is on the end of a phone. So these physician assistants are in all remote areas and they are conducting different cases. They tend to use a TCI of propofol and TCI of remifentanil. Why? Because they are both short-acting, they are readily titratable. The remifentanil will give you analgesia when you need it, until you stop needing it. They have both got minimal hangover effects. The patients are still spontaneously breathing, and there is a minimal recovery time. The patient rolls over and they wake up, and that is the beauty of using a TCI propofol and remifentanil. This is the other diagram that he showed. Loss of response to an esophageal instrumentation happens very quickly. Ventilatory depression is happening in front of your eyes, and responsiveness to verbal stimuli. So you can look at all these three and decide how much propofol and how much remifentanil you want to give to a particular patient. TCI propofol is done as an effect-cited, titrated, targeted increments. That means you look at the patient response. If the patient moves, you give a bit more. But the remifentanil TCI is kept constant at only 1 nanogram per ml. No matter how big the patient is, how small the patient is, you do not change the dose of remifentanil. You change only the TCI propofol dose. So after this case presentation, I just wanted you to be aware of a case that I did, looking at the Netherlands case, I did a implantable cardioverter defibrillator, the implantation of that in a patient in this format. So this is a device that is put on the left side of the patient and is quite a big area in which the cardiologist actually makes a cut. He implants the device and then they put subcutaneous 2 wires. The patient was a female, 64 years old, who's got a BMI of 42. She's an asthmatic, hypertensive, has got rheumatoid arthritis affecting mainly the hands. She had OSA with CPAP machine. She's a long COVID with shortness of breath. Fibromyalgia, allergic to penicillin. Her ejection fraction was only 21%. And a MDT between myself and the cardiologist was done 4 days prior to the procedure. Preoperatively, we had a team brief on that day. A WHO checklist was done. I instructed them to give IV paracetamol and antibiotics on the ward. In the theaters, we had done a full machine check. Full AGBI monitoring was started. Oxygen via capno mask was started. I had 2 IV cannulas, both on the right side. The left side is not usable because it's on the side where the procedure is being done. I had propofol TCI ready with 1% propofol TCI of remifentanil with 50 microgram per ml as 2 milligrams in 40 ml of normal saline, and a metaraminol infusion in case the patient dropped their blood pressure. I was running a plasma-like fluid 1 liter very slowly. I advised the cardiologist to use lignocaine 1% with adrenaline so that he was able to use larger amount and used it very safely. It landed up to be a 3-hour case and the total blood loss was quite minimal. During the whole procedure, I titrated both TCI to effect of the patient consciousness, pain, movement, comfort, and of course, capnography. In this patient, in 3 hours, I used a propofol TCI dose of a total of 300 milligrams, and I kept it as little as 1 microgram per ml. Similarly, for remifentanil, the dose was less than 0.5 nanogram per ml. My experience, my personal experience in ASA 3 and 4 patients. So when I'm doing an endoscopy sedation, I tend to use propofol TCI and tell the operator to give a generous amount of lignocaine throat spray. If a patient requests a GA, I paralyze them and put in an endotracheal tube. For cardiology sedation, such as cardioversion, I use only propofol in the way of boluses. 30 to 100 milligrams, a very tiny dose is needed. Remifentanil and propofol TCI for longer cases. When I'm using nerve blocks done by orthopedic surgeons, I'm using only propofol. I've stopped giving any opiates because I'm requesting the surgeon to use generous amount of 1% lignocaine with a very small needle before they insert in the big spinal needle. In the radiology cases that I have been involved, I use propofol TCI and fentanyl or remifentanil infusion for long cases. This is the main crux of preventing any adverse event in any patient: head tilt, chin lift, and a jaw thrust, and keeping the right size of the airway near us. Thank you very much for listening to me, and thank you for giving me this opportunity to present. Thank you.
Okay. Sonia. Okay. Thank you very much, Sonia, for excellent presentation. I know this is a very this is a very complications can happen in this area. This is a very you have warned everybody that we need to be very careful. Thank you very much.
Thank you.
Okay, we'll go to the next presentation. This is my presentation, and okay. Thank you very much for Dr. Radhakrishnan. You have already introduced to me. So, okay, we're going to my presentation. My topic is management of parturient with familial hyperchylomicronaemia syndromes with hypertryglyceredemia. Okay, our patient, they are actually, this is one of the patients that came into my list. I did personally, of course, I also supported with my colleagues. And our patient is a 29-year-old Bulgarian parturient. She needed an interpreter. She's 34 weeks gestation on the day of operation. She's gravida 3, para 2, 2 spontaneous normal deliveries. She was admitted to the hospital 3 weeks before the operation with epigastric pain and low blood pressure. And she was BMI 41, suspected of acute pancreatitis and pulmonary embolism. And later it was investigated when she was diagnosed with the diabetes and hypertriglyceridemia. So during the 3 weeks period, she was investigated for all the conditions, and then the issues came, or familial hypertriglyceridemia. Triglycerides range from 9 to 17 millimoles. Normal is less than 1.8, and her cholesterol is 9.2, normal is less than 5. So she was also initially suspected as an acute pancreatitis and later ruled out. A history of gallstones and fatty liver, persistent tachycardia. For that, VBAQ scan was done to rule out PE, and she had a mild pericardial effusion on the echo, which is around 8 millimeters, and he has a normal systolic LV function. She is diagnosed with non-insulin dependent diabetes on metformin and on insulin infusion. Her hemoglobin A1C was 76 millimoles. She was anemic with 7.8 milligrams on admission and BMI of 41. So the obstetric team, they have discussed with the tertiary center, and then they have made a preoperative plan. After discussing with a multidisciplinary team, the patient to be moved to a consultant-led cesarean section list and notified to the consultant anesthetist, surgeon, and a pediatrician, book a double slot theater to give adequate time for the stop, and patient should go first on the list, and then cell-saver issues to be left to the team to decide, and 2 units of blood to be cross-matched, not to be given in pre-op. And then repeat the clotting studies at 6 a.m. on the day of the operation, and an anesthetic review against before the operation. So these are the laboratory data. Her 2 days before, her hemoglobin is 8.5 and triglyceride is 10.6. On the day of the operation, these are the blood gases. Nearly the midnight before, the base excess is minus 5.3 and lactate 1.3. And on the just before the operation, base excess is minus 6.2, lactate 1.1. And this is at the end of the day, the base excess is minus 7.2 and lactate 1.8. So the anesthesia of the preoperatively patient was reviewed by a couple of times by the anesthetist during the 3 weeks. And then there was a multidisciplinary team discussion was happened, and they have decided, including hematologist, they have agreed for to cross-match only, not to transfuse preoperatively unless if it is necessary. And she was planned for a spinal anesthesia, and she came to the theater with a glucose, potassium, insulin sliding scale. And we have inserted a 16-gauge cannula, and then we put an arterial line on the left radial, but the trace is damp or not happy, and the person is 90 systolic. So we repeated the outline on the right side, on the right radial, and with a good trace, 106 millimeter systolic. So spinal anesthesia was administered with 2.4 ml of 0.5% heavy marker with 12.5 micrograms of fentanyl in sitting position. Simultaneously, a phenylephrine infusion is started with a 40 ml per hour with a concentration of 50 micrograms per ml. And baby boy delivered with a good upgar of 10, blood pressure managed with phenylephrine infusion and boluses, and the blood loss is 500 ml. At this stage, the transfusion is postponed and give it in the postoperatively if it is necessary. So postoperatively, later she was moved to the maternity enhanced care unit, and a hemoglobin came to 9.2 in recovery, involved the medical and endocrine teams for further management. So during this one, here is the issues, controversies, and challenges. What were the issues that we faced? One is the hyperviscosity. See, what happened is even the blood samples we sent to the lab, they were denied, rejected. We need to repeat again. On the day after the operation, even the clotting sample is also rejected. So we need to redo again. Second is cell savers. So we don't have adequate enough evidence whether the cell savers can work with patients with hypercholesterol or hyperviscous blood. The filters can block, and also the churning, revolving, shearing, and centrifuging forces in the cell saver can and their impact on the red cells. We don't have any evidence. So at the end of the day, maybe we might transfuse the damaged red cells, and then that could have a more damaging effects. So we decided not to use the cell saver in this scenario. So the technical difficulties, dampness, arterial traces. So need to do the second arterial line. The third discussion is the anemia thresholds. So at what level we should give the blood? The issue is because the patient is a hyperviscosity. If you are giving a packed cells to a hyperviscosity blood, and its impact on the thrombotic phenomena, we're not very clear. So what we have decided a rational approach is wait until keep the blood a couple of units of packed cells ready. When the patient really falls to a certain level, give an adequate fluids to make hydration, and then give the packed cells to maintain the viscosity, normal viscosity state which patient is habituated. The other issues is the low blood pressure, and then ketoacidosis and its anesthetic complications. The third issue is the pericardial effusion. Her pericardial effusion, of course, it is in 8 millimeters, which is the higher side of the lower mild pericardial effusion, but it can have a 30% tamponade effect. So obesity, BMI 41. So what happens is when a patient with a high BMI, some mild pericardial effusion with a ketoacidosis, low blood pressure, with a spinal anesthetic, when she lies on the flat, so with a hypercaval compression, which reduces the cardiac output by 40%. So, and what is their effects on the maternal and fetal physiology, maternal fetal perfusions? So these are all the challenging issues. Of course, we have managed. Of course, we have taken some ergonomic situation of the staff also, where what we have discussed is we have asked the staff, surgeons scrub ready, and then the nurses, midwife who is going to catheterize her also ready. As soon as we have given the spinal, they immediately connect on the catheterization and surgery, go ahead with the study and deliver the baby as early as possible. See, once if the baby is delivered, then our options are more. So we have many options for the anesthesia. So the discharge summary by the endocrinology team on the 8th day, by the time patient is off from the insulin and fibrate and Omicron, and then triglycerides seem to have stabilized around 12 to 13 millimoles, and then they have advised continue metformin, and then restart the icosapentagonate and DHEA esters, 2 grams BD, repeat the triglycerides and lipoprotein level, B levels in a week later, and advise a diet on discharge, a general diet focusing on whole grain, carbohydrate, healthy protein and fats. An endocrinology review in 2 weeks and follow up in the adult metabolic tertiary center. So overall, the case is managed with the multidisciplinary teams involved the obstetric, anesthetic, critical care, and tertiary team, which is our teaching hospital in London, the Guy and St. Thomas Hospital, medical teams on call, cardiorespiratory, endocrinology, maternity and enhanced care unit. And finally, patient was discharged on the 8th day. So I'm going to share this is the guidance which was given to us by the tertiary team, tertiary hospital. Usually because these cases are very rare, they are not very common. So this as per this guidance, triglycerides more than 10 millimoles increase the risk of complications such as hypertriglyceridemia, which are related to acute pancreatitis and hyperviscosity syndrome. So hypertriglyceridemia can be primary or secondary. Primary related to conditions like monogenic conditions collectively known as familial hyperchylomicronaemia syndromes, or secondary, which are related to poorly controlled diabetes, excess alcohol, or diet rich in carbohydrates. So these patients present to the hospital in 2 ways. One is patients who are known to have familial chylomicronemia syndromes. These patients are already registered with the tertiary center in their lipid clinic. Their high triglycerides were picked up in the during monitoring and surveillance of the bloods, or they might have presented to abdominal pain, nausea, vomiting in some other hospital, or they was also reported to hyperviscosity syndrome. So they were already investigated. The tertiary center will have a record of those things. The other group of the patients who are not known to have a familial chylomicronemia syndromes, they have a very high triglyceride levels. They are picked when they admitted to the hospital for some other condition like a diabetes or like other surgical condition. Or they are also present with features of acute pancreatitis or hyperviscosity syndrome, or when the bloods are noted when they're taken on admission. So this guidance is mainly related to the adult patients with hypertriglyceridemia more than 20 millimoles. They may present with complications like acute pancreatitis or hyperviscosity syndrome. If they do, they should be managed with evidence-based approach. So asymptomatic patients and triglycerides more than 50 millimoles. If they come to the hospital, first you need to exclude the diabetes or excess consumption of alcohol or other causes and manage appropriately. And then you refer to the lipid clinic. But if they are acutely ill, the triglyceride is more than 20, they need an immediate admission to the hospital and investigation. So they may need referral to HDU, ITU, and if the patient is clinically unstable or GCS less than 8, or if the patients are having a diabetic ketoacidosis. So this is the flow chart the tertiary center has given to us. So if you suspect any hypertriglyceridemia more than 20 millimoles, first rule out the acute pancreatitis. If yes, refer to surgical team. If no, then try IV cannula fluids and bloods and refer to obstetric team and all full lipid coagulation, urea and electrolytes and full bloods. And then now next rule is the diabetes. If the patient is diabetes, follow the diabetic protocol. If not diabetic, then prescribe the fixed rate insulin, fluids, normal saline with potassium, 10% dextrose. And if they're diabetic, put on insulin and hold sulfonylureas and prophylactic deltaparin and statin. And then for follow up and inform to the diabetic team, endocrinology team will follow with the diabetic consultant and the dietitians. This is the other management. Suppose if the patients are admitted in the hospital and then they should be monitored every 4-hourly blood gases and blood glucose and ketones, triglycerides, lipids. So if within after 40, so when they should be considered as stable. So if their triglycerides are less than, if they are after 48 hours, if the triglycerides are less than 50% of when they were admitted, or they are clinically ill, they should be considered for plasmapheresis. Or once if the triglycerides come to less than 20 millimole, then they could be referred to the endocrinologist. So if the triglycerides are more than 20, and if they're not coming after 40 years less than 50%, then you need to discuss with the biochemistry and endocrinologist. Once if the triglycerides come to less than 20 millimoles, then the endocrinology team can follow up for further management. So there are just some general guidelines in the perioperative care of patients with inborn error metabolism. So usually these patients, some of the important points are easily anticipate metabolic acidosis, avoid prolonged fasting and provide supplemental glucose, avoid Ringer's lactate, prevent aspiration. Serious possible risk is there, risk of coagulopathy, electrolyte abnormalities, needed correction, invasive monitoring, and involvement of muscle leading to succinylcholine and risk of inhalation anesthetics. So the causes of hypertriglyceridemia, okay, one is familial, it is a familial chylomicronaemia syndromes, or the secondary due to chronic kidney disease, liver, drug-induced excess alcohol, hypothyroid, metabolic syndrome, obesity, and poorly controlled diabetes and other glycogen storage disorders. So these are patients come across the following groups of medications. They are on the statins, fibrates, omega esters, ezetimibe, niacin, niacin. So my learning point in this case is a multidisciplinary approach involving various specialties, including tertiary centers advised with a well-coordinated activity of all members, aiming to maintain normal homeostasis of mother and baby as near as possible with normal physiological parameters throughout the perioperative period, while simultaneously addressing the clinical challenges with the rational use of senior anesthetic surgical expertise and techniques is essential to improve the outcome. So a little bit of going back to the biochemistry and the physiology. Fatty acids in the human body are classified into 4 types. One is saturated, monosaturated, polyunsaturated, trans fats. Saturated fats have no double bonds. They raise LDL cholesterol and risk of heart disease. Monounsaturated are one double bond are healthier than saturated fatty acids. Polyunsaturated fatty acids have more than one double bond and have a significant this is the same slide. And trans fats are mainly used in the processed foods. Okay, basically, fatty acids serve as an energy stores that can be mobilized to yield acetylcholine. So fatty acid metabolism involves 4 stages. One is the carnitine cycle, beta oxidation cycle, electron transfer, ketone synthesis. Carnitine cycle mainly is important to transport the long-chain fatty acids into the mitochondria. Beta oxidation mainly produces reduction from long-chain fatty acids to short-chain fatty acid and resulting into the acetylcholine. Then electron transfer is required for the transport of electrons and formation of the ATP. And then ketosynthesis is required in the case of starvation. So this is the diagram which briefly explained to you the interlink between all these things. Usually, whenever the long-chain fatty acids are entered into the cell, they are transported by the carnitine into the mitochondrial matrix. From here, so carnitine is very essential. So once the long-chain fatty acids are transported into the cell, here they go into the beta oxidation. Beta oxidation basically from long-chain fatty acids to short-chain fatty acids. So that will finally, they reduce it into acetylcholine. Acetyl-CoA will go into the Krebs citric acid cycle and then it will go into the ATP production in a normal. If there are any inhibitions or if there are accumulations or if there is any deficiency of the enzymes, acetyl-CoA is accumulated, which is mainly accumulated in the heart, skeletal muscle, brain, and liver. So these are the 4 organs get targeted and also deposited in the liver. So this is how acetyl-CoA metabolites are deposited. So carnitine is if there are any defects in the carnitine cycle, mainly affects liver, heart, skeletal muscle. So metabolic, including hypoglycemia, metabolic acidosis, and hyperammonia can result in encephalopathy. So anesthetic considerations is avoid catabolic states by the provision of carbohydrate-containing fluids, evaluation for evidence of cardiomyopathy and coagulopathy, and avoid depolarizing muscle relaxants and sevoflurane in risk of malignant hyperpyrexia, rhabdomyolysis, and hyperkalemia. A subtoxic dose of local anesthetic may cause cardiotoxicity because of increased susceptibility to the local anesthetic systemic toxicity. Because this is especially if you are using a local anesthetic like bupropion. So you need a cardiac monitoring. The other is the defects of the fatty acid oxidation. Fatty acid oxidation, defects in the fatty acid oxidation are numerous. There are many enzymes are involved. So, but they predominantly affect the liver, heart, skeletal muscle, and there's especially when some forms such as medium chain acetyl-CoA deficiency can only cause liver dysfunction and spare cardiac and skeletal muscle. Electron transfer defects are very rare. They are not very common, but usually they typically present in the neonatal period. But usually very few patients survive until their adulthood. But if they are present, they may cause metabolic crisis. So there are various anesthetics were reported in different groups. So for a short chain acetyl-CoA dehydrogenase deficiency, again the principles is carbohydrate containing fluids, midazolam ketamine, termidate, fentanyl, cisatractidum, dexamethasone. Of course, in this group they have tried with isoflurane and avoid propofol. For a medium chain acetyl-CoA dehydrogenase deficiency, they have successfully anesthetized with midazolam, propofol, thiopentone, and sevoflurane. Okay, so finally, these are the issues and controversies we have faced, and that is my end of that talk. I think we have taken enough time. Now we can invite questions and answers.
I think, Sonia, there are some questions for you. One of the questions I'll read out from the chat box if no one's monitor. The question from Dr. Irfan Hussain is, what's your go-to sedation technique for ERCP and colonoscopy? And also at their center, they don't have end-tidal CO2 in the GE suite. So is there an alternative for monitoring ventilation?
In our hospital, the ERCPs are done by a sedationist. As anesthetists, we are not getting involved. And the patients are prone and they are being given midazolam and pethidine instead of fentanyl, so that it relaxes the sphincter of Oddi and they are able to put that in. For colonoscopy, we are giving, they are using midazolam and fentanyl and also gas and air. So Entanox is also promoted to be used. They do not have end-tidal CO2 in the suite, and we also did not have it. So what we have done is purchased mobile Portex monitors on which you can put in the CO2 monitor. And this is the important thing. There is no other thing for monitoring ventilation. Unfortunately, as an alternative, there is nothing. You have to use end-tidal CO2. And in the UK, as per the AGBI recommendation, we cannot give anesthesia or we cannot even touch a patient as an anesthetist. Whether it be sedation, whether it be general anesthesia, we are not allowed to touch a patient without standard monitoring, which includes capnography. So you have to emphasize on the importance of capnography. There are many articles which can do it. You can use this lecture and you can use the slides from here, no problem. But that at the moment in UK is so-called recommended by the Academy of Royal Colleges. But in the very near future, it is going to become mandatory.
There's another question for you from Dr. Muthukapar Tajagopalan. Can etomidate be used as an infusion for sedation outside OR? I've never.
Again, I have read about it in one of the papers, but personally, I've never used it. The other thing is in UK, etomidate is not found on the shelf anymore. So when I joined UK, when I joined this hospital 22 years ago, I could say there were about 3 or 4 ampules of etomidate which were in the hiding. But I would say in the last 15 years at least, I have not seen any etomidate. It has been wiped out in UK. So we haven't got any stock of it, and I have never ever given it for sedation. So that's personal. What I'm telling you.
That's yeah. Do you have any more questions? So can you see any, Tara? I can't see any more here.
No, I opened it,
Okay.
and
Okay.
that's what I found too.
Okay. Yeah, then we will hand over the session to Dr. Radhakrishnan, and thank you very much, Dr. Radhakrishnan, and all the senior members of the college for giving this opportunity. But okay, before we have one more question to Sonia. No, it is for me.
It is for yourself.
Yeah. Rajgopalan, that should these patients with hypertryglyceridemia be given anticoagulants or aspirin? Can we give regional anesthesia if they have not stopped, if you are taking these patients for emergency? Okay, here 2 principles is one, yes, definitely there are a higher risk of it is an hypercoagulable state. So they should be covered with anticoagulation as soon as admitted. So now the principles, if they're going for a surgery, then you have to follow whatever the recommendations, whether it is a 4-hour or 6-hour or a 12-hour, depending upon the anticoagulation you have given. And it should be stopped. Suppose if it is an emergency surgery, they might need a bridging therapy also. So can we give a regional anesthesia if they were again basically once if the patient comes, you start anticoagulation and then you stop accordingly and then you go ahead with regional anesthesia. Still the regional anesthesia is safe because the choice of anesthetics in my favor is first spinal because it is having a very minimal medications. Second thing, and you will have a better control of hypertryglyceridemia and blood sugar. Second issue is epidural. I am little bit less inclined because these patients can have a cardiotoxicity because their myocardiums are already accumulated with these siRCoNMA metabolites. So there is a risk of subtoxic concentrations of anesthetics can cause cardiotoxicity in this patient. So if you're giving epidural, you keep an eye on the how much ibuprofen you are using. So especially if you're giving again using an epidural for a pain relief in the liver is also tricky. Again, you are going to a higher dose of ibuprofen. Again, general anesthesia, yes, definitely avoid propofol infusion. You can avoid depolarizing muscle relaxants. Inhalation anesthetics is a controversial, especially if there is any query of genetical issues. No, do not use inhalation anesthetics. For only beta oxidation issues, metabolism defects maybe can right? Because a couple of reports were they tried with isoflurane. That is the one. Okay, right. Any more questions? No, we can go. We can. Dr. Radhakrishnan, you can take over.
Thank you, Raju, Tara, and Sonia. Thank you for the excellent webinar.
Thank you, sir.
Well, the procedural sedation which you are telling is excellent.
Thank you.
But unfortunately, we don't have a protocol in India. A national protocol is not available. Institutional protocols are there, and they follow institutional protocols. Regarding cardiopulmonary testing, Dr. Tara is still being not that popular in all the institutions. But in major institutions, cardiopulmonary testing is getting popular, and they go for cardiopulmonary testing and prehabilitation, because that's a must there. But in the government sector is not that much equipped. That's one of the reasons. And people are not that much keen to go for cardiopulmonary testing, but they go for a detailed pre-anesthetic assessment, and if necessary, go for prehabilitation with exercise, rotational support, and drug support. Anyway, they used to have extra care. But I'm sure within another 2-3 years' time, the cardiopulmonary testing is going to be mandatory here also.
Yes.
And Raju, thank you for the case discussion. It's a wonderful case discussion. Well, we usually don't come into that particular picture with these sort of cases, but somehow it's all being done without much disabilities or difficulties. Anyway, you have all done a wonderful presentation. Thank you very much. And we look forward to have these sort of presentations in the future also. And on behalf of Indian College of Anesthesiology, we thank you all for being with us and teaching us on all these particular new many ways. Thank you.
Thank you. Thank you very much.
Thank you very much, Dr. Radhakrishnan. Thank you.